Hello, I'm Miguel Regueiro. On behalf of CME Outfitters, I'd like to welcome you and thank you for joining us for today's educational activity entitled The Important Role of Preventive Screening in IBD. How, who, and does it matter? Today's program is supported by educational grants from AbbVie Inc., Janssen Biotech Inc., which is administered by Janssen Scientific Affairs, LLC, and Takeda Pharmaceuticals USA, Inc. Today's activity is brought to you by the award-winning CME Outfitters, which is an accredited provider of continuing educations for clinicians worldwide. I'd also like to encourage everybody to join us on our live Twitter conversation at CME Outfitters. Again, that's at CME Outfitters. We'll be monitoring the Twitter feed and responding to your tweets as they come in. One last item I want to note is that we are using an enhanced platform today that allows you to save slides, take notes on slides, answer your polling questions, and send us your questions as well. Please look at the tabs on the left-hand side of your screen and give us feedback on the program and the platform as well. As mentioned, I'm Miguel Regueiro. I'm chair of Digestive Disease and Surgery Institute at Cleveland Clinic in Cleveland, Ohio. And first, let me welcome my colleague, Dr. Florian Rieder. Dr. Rieder is the Vice Department Chair, Co-Director of our IBD section, Director of our IBD Advanced Fellowship, and also part of our Department for Inflammation and Immunity in the Lerner Research Institute. Welcome, Florian, and thank you for joining me today.
Thank you, Miguel, for having me for this important topic. And I'm also happy to have our global IBD family from the Cleveland Clinic represented.
Great. Yeah. And so on that note, perfect segue. Also assisting us this evening by providing video vignettes is our colleague, Dr. Sara Ouali. She's the director of our Inflammatory Bowel Disease Service Line in the Digestive Disease Institute at Cleveland Clinic in Abu Dhabi. She's also a staff physician there, clinical assistant professor of medicine at Cleveland Clinic Lerner College of Medicine. Dr. Ouali is unable to join us this evening, but we thank her for providing information on this session and her pre-recorded vignettes, which we'll show you in a minute. So first, let me now review our learning objectives. Our first learning objective is to integrate preventive screenings into practice to improve health outcomes in all patients with IBD. Our second learning objective is to initiate interdisciplinary collaboration to provide optimal care for patients with IBD. And you'll hear from both Flo and I about this aspect of interdisciplinary care throughout the course of tonight's programs. So let's first start with a case and a patient that is named Lynn. Lynn is a 30-year-old African-American female, newly diagnosed with moderate to severe ileocolonic Crohn's disease, prescribed 5 milligram per kilogram of infliximab, 15 milligrams of methotrexate a week, and this was started about 6 months ago. Her symptoms have improved, but are now back to baseline. She reports that the burden of her disease is making her very sad, as well as anxious about attending social gatherings. She states that she notices certain foods trigger her symptoms, and she asks for information on special diets that will ease her symptoms. So this is something we'll discuss in a minute, but before we move into the data, I'd like to get our audience involved at this point. You'll see the question on your screen, and you can choose from the responses now. What kind of healthcare maintenance would you recommend in our patient, Lynn? A, vaccination history. B, depression and anxiety screening. C, colonoscopy. D, cervical cancer screening. E, all of the above. Or F, I'm not sure. So go ahead and vote now. We'll see the results here in a minute. And then Flo, you and I actually will take a minute here to discuss what we see on the screen. And also I'd like to get your input as well on healthcare maintenance in general. So let's see what people think. All right, so actually the majority of people, 66%, answered the way I would answer, which is all of the above. And then there was a smaller percentage that was between depression, anxiety, colonoscopy, and an even smaller percentage that says, I'm not sure, which is okay. That's why you're here as part of our program tonight. So Flo, let me start with a vaccination question. And, you know, again, this is kind of Lynn. She's coming in. She's obviously on medications already. But when you see your patients and you counsel your patients, what kind of vaccinations do you tell your patients that they should receive?
Yeah, first of all, Miguel, I'm very happy that 2/3 of our attendance was actually able to get the right answer, which is all of the above. And all these items we will talk about in the next 30 minutes or so. In this patient that is on double immunosuppression with infliximab and methotrexate, I think it's important to talk about which vaccinations are important. And this includes additional vaccinations to the standard ones that I assume the patient already received, such as, for instance, hepatitis A as well as hepatitis B, the pneumococcal vaccinations, and there are two of them called PSV23 as well as PCV13. We talk about their combination in a minute. And I would also recommend to these patients the shingles vaccine, given that she is on dual immunosuppression. There's a yearly flu shot that we anticipate this patient to have, and we would like to have this patient also to be vaccinated for COVID.
Great. So that's a kind of a nice overview. And I know we're going to talk about vaccinations a little bit. And actually, we're getting some great questions coming in. So for those out there, please keep sending your questions. Maybe I'll ask a question about vaccine hesitancy and then one question on diet, and then we'll probably keep going and get to some of the other questions as we go through this. So Flo, you know, there's certainly in general, but over the last couple of years, there's been a lot of vaccine hesitancy, which comes from a variety of reasons. But how do you manage that in your patients? Kind of when they come in and you recommend vaccines and they're somewhat hesitant, what's your approach to that?
So I generally try to understand first why the patient is hesitant to receive the vaccine, and we can talk about the reasons in a few minutes. It can be because the perceived risk of the preventable disease is low. It could be related to health literacy. It could be related to trust to the physician. And depending on the answer, I would then attempt to recommend the patient an approach. But overall, I think it's important to leave the patient room to have their own decisions, to make their own decisions, rather than being forced into it.
Yeah, so I think that shared decision approach that we always talk about is most important around the vaccine hesitancy. And I also agree, I think some of it is understanding why they're hesitant or why they're afraid. I know we work in a center where we actually have an IBD pharmacist, and we'll come to the team in a minute. But sometimes when we know a patient may need a little bit more education and time on the topic of medications, but vaccines, we have our pharmacist get involved as well. So I think,
oh, sorry.
Yep, no, go ahead.
I just wanted to mention, I think you made an important point with the time factor. Vaccines are never an emergency, and I think it's worth leaving the patient the time to make these decisions, because that will also have an impact on the general care physician to patient relationship and how many other vaccinations the patient is willing to take.
Yeah, and I think so. That's so important, and I'm glad you brought that up and emphasized that. And one other question I see a lot of is, you know, what are the must-haves on your team? And maybe to segue into this, and I'll give you my bias, I think having a dietitian is a must-have, and I think we've learned, both of you and I collectively in our center here and others, but is there a particular diet you recommend? And then what are your must-haves as far as team members in this medical home or medical team environment?
Yeah, diet questions come up very frequently in our patients with inflammatory bowel disease. And at this point in time, the general recommendation is that any diet that is healthy for a non-IBD patient is also recommended for an IBD patient. There's currently no diet that we can recommend that either prevents inflammatory bowel diseases, prevents a flare, or treats a flare. So what we are trying to do is ensure a healthy, balanced diet in our patients, ensuring enough calorie intake and that there is no, for instance, weight loss in relation to avoiding foods. And then we try to probe if certain foods elicit certain symptoms, such as FODMAPs group, for instance, that cause bloating. And with the help of a dietitian that Miguel mentioned, who is an integral part of our team, we try to find out which food groups the patient can avoid to have a better quality of life.
Yeah, so I think that's, and just to add a little bit more to what you said about diet, and I completely agree. There's no one diet that we found that cures IBD. There have been some studies on diet, such as the specific carbohydrate Mediterranean. And I think just as a rule of thumb, tending to look at the Mediterranean diet more and more as maybe the baseline healthy diet that if our patients can adhere to, but including the dietitian. And then the final comment I'll make before I ask you to talk about screening is other must-haves on the team. We hear that our patient has some depression, anxiety. I think having a behavioral health specialist is so important, and that can be a clinical social worker, psychologist, less commonly a psychiatrist, just because of the demand for psychiatry now. I think the social worker and the psychologists are playing this role. All right, so Flo, let's switch gears because we're getting a lot of questions. I think the more you talk, the more good questions come in. So we'll get to as many of these we can by the end of the program. But talk about the recommended screenings for patients with IBD.
Yeah, so for all patients with inflammatory bowel disease, we recommend to screen for latent tuberculosis at baseline, including to other labs, such as, for instance, prior exposure to hepatitis B. And we want to be preemptive if a patient gets started on a biologic, that we know about this. We screen for smoking status, and we recommend smoking cessation therapy in case a patient is an active smoker. And this is also true for ulcerative colitis, where it has been shown that stopping to smoke may actually increase disease activity, but the benefit of stopping smoking far outweighs the risk of potential increased inflammation in ulcerative colitis. And the point that Miguel highlighted is a luxury for us really at the Cleveland Clinic, where we have our own inflammatory bowel disease psychologist. But even in routine clinical care, it has been shown to be beneficial to screen for depression and anxiety at baseline. And our patient that was presented here, in fact, may have both of those. There are validated tools available called the PHQ-9 for depression and the G87 for anxiety that have both been validated. And you can find them online, for example, on websites such as MD-Calc, that you not only get a value, but you also get an interpretation. We also recommend to do this annually. For patients that are on systemic immunosuppression, and systemic immunosuppression here is defined as more than 20 milligrams per day of prednisone for more than 14 days, as a thioprin more than 2.5 mg per kg per day, or mercaptopurine more than 1.5 mg per kg per day, methotrexate more than 0.4 milligrams per kg per week, which for an average weight individual is about 25 milligrams per week, cyclosporin, tacrolimus, or in fact, any biologic with the exception of vedolizumab. For these patients, we recommend an annual total body skin exam to screen for skin cancer, and women should undergo cervical cancer screening by cytology annually, or if HPV is negative, every 3 years.
Great. And actually, there was a question while you were talking about the skin exam, and I think this is certainly relative to our patient that we present here. How do you screen for melanoma in patients with darker skin? If so, how often? How's that done? What's your approach to that overall?
Yeah, so we recommend to have this done by a dermatologist, and they often have special clinics for immunosuppressed patients, where either a dermatologist or a physician assistant or nurse practitioner performs a whole body exam. And we recommend sun protection measures for patients on immunosuppression, irrespective of skin color. And one critical point, Miguel, that you're making is in patients with darker skin tones, it is in fact more difficult to identify certain skin lesions such as melanoma, which emphasizes the need to have a specialized care, in this case, a dermatologist.
Yeah, so I think that dermatologists, for those that aren't familiar with the skin exams, have these kind of optical devices that they can use to look for hyperpigmented spots. I'll be honest with you, I'm not great at a total skin exam myself, and I think calling on our colleague who can help with this is so important. We'll get in a minute into some of the questions around how do you access these medical teams or medical homes if you're out in the community. And I think a lot of people online are listening or are in their practices and may not have this multidisciplinary care team. And I think we'll come to that in a minute. But I want to switch gears now and pull in Dr. Ouali, who has a real nice video on health maintenance. And so let's hear what Dr. Ouali has to say about health maintenance and how she integrates this into her practice.
Health maintenance can be really difficult sometimes to fit into our busy clinic schedules, but it's really important to try to make that time for it because we first know it leads to better outcomes. And the other thing is that it allows us to kind of have a holistic view over some of the issues that can affect our patients. Some of the things that have helped me throughout the years to better care for patients and cover health maintenance more systematically have been that, first of all, when they come and they're not doing well and they're quite sick, that's not the right time to cover health maintenance. But what I do tell them is we'll cover the acute issues. And at the end of the visit, I tell them, listen, we need to remember that next time we need to cover this health, the different aspects of health maintenance. And I do make a note of it in the chart as well, so that I do remember that. And then when they do come for health maintenance visits, what I do is I can go through the checklist. There are a couple of checklists that are really helpful. One from the Crohn's and Colitis Foundation of America, and the other one is from Cornerstones. So I go through them so that I don't miss anything. But what I often do is I have my own short list of things that are more relevant to our patient. And I do cover that and I put that in the chart. And then the other thing is that, it's okay to not cover everything during one visit. Sometimes health maintenance can take a while. But what we do is essentially we try to cover the things that are the most urgent or overdue. I definitely tend to cover COVID-19 vaccinations with all my patients these days. And then the last thing is if you're lucky enough to have some help in the clinic with an IBD nurse or coordinator, I definitely, schedule them with them to cover health maintenance as well. So I think it really helps overall. And I think our patients really appreciate the extra time we take to cover these things.
All right. Well, that was great. I think that patient interaction and seeing kind of Sara talk about health maintenance, bring it to life is really good. And I want to move back to you, especially given what Sara just talked about, and look at recommended screenings for patients with IBD and special cases. So we recommend these screenings on patients with immunosuppression. You alluded to some of this already, but what additional screenings would you recommend?
And in our patient that was presented earlier with Crohn's disease, we also know that these patients can have a higher risk for colitis-associated cancer, just like an ulcerative colitis. However, here it depends on how much of the colon is affected, and this is the histological disease extent rather than the endoscopic disease extent. And the threshold is more than 1/3 of the colon, which then qualifies you for a surveillance program that you start at least 8 years after the diagnosis of inflammatory bowel diseases. And after that, you stratify the patient based on the risk factors, with the strongest risk factors being primary sclerosing cholangitis, prior history of dysplasia, presence of colonic stenosis, or a family history of cancer. But another big bucket that you take into consideration for the screening interval between 1 and we actually use 5 years, not 3 years, is what is the cumulative inflammatory burden. And what do I mean by that? The disease extent integrated with the disease activity. So if you have disease in the entire colon and your disease activity is very severe over many years, you have a higher risk for cancer. These recommendations may change over time, and there is currently a big discussion led by the AGA with recent guidelines that may introduce a few changes, but I think what is depicted here on the slide is currently still the standard. Another factor that often gets overseen is bone health. And patients need to be screened for osteoporosis in inflammatory bowel disease of the hip and spine because they have a higher risk for osteoporosis based on prior or current steroid exposure. And the key here is if any of the risk factors for osteoporosis is present, which is malnutrition, a low BMI, more than 3 months of cumulative steroid exposure, smoking, postmenopausal, if any of those is present, you should get a DEXA scan. If the patient has osteoporosis, you should refer them to a bone clinic, and the DEXA scan should be repeated in 5 years.
Great. So I think that's a great continuation of some of the screening that you talked about. And maybe in the next couple of slides, I'll take a crack at some of what Sara was mentioning about the prevention checklist. So monitoring and prevention checklists. And she talked about these kind of lists, and you can see this on the slide. It may be hard to read entirely, but this is from Cornerstones. We put the link here, but I do want to remind people that this is also on our CMEO gastroenterology hub on the CMEO website. And then the next checklist is the health maintenance checklist, which is from the Crohn's Colitis Foundation, which can also be found on the CMEO website. So Flo, maybe one question with this, and I'll kind of answer it and then maybe hear how you do this too. A lot of times the primary care doctors feel that there's a gap between kind of the understanding of what vaccines are given and what the GIs are assuming that primary care doctors are doing. One thing that we're taking on more and more is responsibility ourselves in the electronic medical record that have these best practice alerts or health maintenance checklists, where some of our team, our nurses, our APPs, our pharmacists are doing a very good job at making sure our patients are up to date and also relaying that back to the primary care. So we don't only rely on the primary care, we actually work together as a team. I don't know if you have anything to add to the checklist that I just mentioned, and then we'll go to another audience response question.
I'm just highlighting one point that you made, Miguel, which is communication. And often the patient gets lost between the primary care provider, assuming the gastroenterologist is taking care of healthcare maintenance. And the gastroenterologist thinks the primary care provider does, who often feels overwhelmed by complex patients on immunosuppression. And this communication can happen through electronic medical records or other means, particularly with electronic medical records. Smart phrases, best practice alerts are a very good way of keeping track. But as you know, in our unit at the Cleveland Clinic, we actually assume the healthcare maintenance of this patient as gastroenterologists by facilitating our IBD pharmacists, nutritionists, psychologists, nurse practitioners, and so on.
Yeah, and I think a couple of people are chatting in as you're talking, as far as how do we let the PCPs know if the patient received a vaccine. I think you kind of mentioned that. And with our electronic records now talking to one another, that's a great way. And sometimes we'll even send a little message through the EMR to the PCP, letting them know. And then to the pharmacist out there, thank you, by the way, for joining us tonight. The retail pharmacist can also provide vaccines, can educate, and I think really relying on our pharmacist team, not only within our centers, but out there as well. So let's go ahead to the next audience response because it does tie into vaccines. Which type of vaccine should our patient Lynn receive, considering she's on infliximab and methotrexate? And Flo, you kind of mentioned this, but for the audience, A, pneumococcal pneumonia, B, influenza, C, hepatitis A, D, hepatitis B, E, all of the above, or F, I'm still not sure. So go ahead and take a minute to answer that.
And Miguel, while the folks on the line answer this question, these checklists themselves, in the absence of electronic medical records, can be used to hand out to the patient, and then you can just check off the vaccination that you administer to them. So in our unit, we use the Crohn's Colitis Foundation checklist, and then for every vaccinations they receive, we essentially just mark it on the paper that then the patient can take to their primary care provider on the next visit to update the vaccinations.
Yeah, I think more and more, and as we can pull up the answers here in a second, these kind of passports, if you will, of health maintenance, which I think is so important. Well, Flo, I think you've done a great job. So 86% of the respondents say all of the above for the vaccines, which is correct. And then there was a smaller percentage across the board with either single vaccines or still not sure. So I don't know there's much to comment on here, Flo, except I'm going to actually ask you to keep going on the vaccinations for patients with IBD and kind of we got into this a little bit earlier, but talk to us a little bit more about vaccines.
Yeah, we already have highlighted the importance of this, and I'm very happy that the audience is receptive to what we are telling them about the vaccinations, because the program for IBD patients on immunosuppression is a bit different than the program that patients are supposed to receive when they do not have inflammatory bowel diseases. And this is true to the immunosuppression they're on, among other factors. And the reason why we try to vaccinate them is because we want to prevent these vaccine preventable illnesses. And just as an example, anti-TNF as the most used biologic in inflammatory bowel diseases, the two most common infections are influenza pneumonia and pneumococcal pneumonia, both of which are preventable through vaccinations. Miguel highlighted the back and forth between the primary care provider and the gastroenterologist, who sometimes feel the other person is more responsible to take care of the problem. So I think the gastroenterologists need to be ready to assume care of these patients. And you can facilitate a team approach for administering these vaccinations in our patients. The interdisciplinary approach here is the gastroenterologist that often manages the patient, but then pulls in other subspecialties that are important, colorectal surgeons. Miguel mentioned the nutritionist, the psychologist, the IBD pharmacist, the nurse practitioners, or a social worker. And these all together form a care team that we at the Cleveland Clinic call the medical home. And you see all the different subspecialties listed here on top, and it includes the primary care provider. And this is a very nice depiction of that, because the primary care provider is not outside of the care team, but really inside of the care team. It needs to be involved in all healthcare maintenance aspects. And on the bottom of the slide, you just see examples for who could assist with screenings and healthcare maintenance factors: a dietitian, nurse practitioner, social worker, psychologist, pharmacist. And these roles that are outlined here are only suggestions. These can be adapted to each practice style and practice pattern. But most nurse practitioners, for instance, can do the entire battery of healthcare screenings. And then other subspecialties like psychologists with specialty training or pharmacists with specialty training can support that.
Yeah, so actually I want to make a couple points while we're on this slide, especially related to some of the questions coming in. One of the questions is, what are some of the tips for keeping the line of communication open, especially if primary care doesn't have an EMR? Do you ever call? So one thing that we'll do, and on the list, actually, we didn't mention the boxes here, but so important are our nurses. And sometimes I'll have my nurse talk to the nurse in the primary care doctor's office and really provide the updates, even from a nurse-to-nurse standpoint, which I think is so important to have that line of communication as well. And the other point I want to make, because we got a lot of questions on how do I do this as a community doctor without the resources that we show you on this slide. And I think we're going to start to build on this concept of a medical neighborhood, which really means that a patient in a region may link into a tertiary care center that has a lot of these care team members, but the maintenance of care continues with the primary gastroenterologist or the primary care provider in the community, which the patient oftentimes doesn't want to drive a long distance. And now with telemedicine and virtual care, there's the ability for the dietitian, the psychologist, the pharmacist to do these virtual visits and still maintain the primary care doctor and primary GI. So I think this concept of expanding medical neighborhood, it's really where I think we're headed in the future. Well, I think, Flo, I want to shift back to Sara, who's not here, but she has another great interaction with the patient. And I want to get a little bit more into the kind of the screening and how we work as a team. So we've talked about vaccinations and screenings, and really do they improve outcomes. So now let's watch Sara's video with a patient as a real important example of a patient and kind of what happened in between them. So go ahead and let's roll the video.
Hi, Jessica. It's good to see you again. How are you doing?
Hi. I'm really good. How are you?
I'm good, thank you. So last time we met was about a month ago. And during that time, I remember we were talking about different aspects of the IBD care. We talked a little bit about moles and screening for moles. What happened after that?
Well, I was actually so pleased that you brought it up because I hadn't realised with my IBD how much more at risk I was with of skin cancer. I'd had a mole which I'd been meaning to get checked, but my insurance had lapsed. And from that meeting, I actually went to the dermatologist and I had my mole removed last week. As you know, they did biopsies and it was cancerous.
I'm sorry to hear that. Did the doctor say whether it was resected and it's okay, it's all done?
It was caught so early that there's nothing more to do apart from keep carrying on with my checkups now. So I'm so grateful.
That's great news. That's great news.
Yeah,
so you do have a follow-up, Jessica?
Yeah. I'll be followed by them now, yeah.
Okay, perfect. It's great to hear. It's really important to cover these things, and I'm glad you were able to figure out the insurance thing because it's really important.
And I just had no idea, to be honest with you. I was at risk, so I'm so pleased we did.
I'm glad we mentioned it. Thank you, Jessica.
Thank you.
I'll see you soon.
Wow, so that was such an important interaction to see, and I think Dr. Ouali did a nice job at showing how we really do need to incorporate screening, and this example of this skin malignancy I think really hits home. And really, as a gastroenterologist, that we can improve screening in our patients, as was seen. And I think it's this trust between the patient and the physician. Also, as I mentioned a minute ago, incorporating telemedicine when we have the opportunity to include others. We didn't even talk about teledermatology, which is actually becoming a field into itself. And so another way to incorporate this medical neighborhood and medical home, even to people who are in areas where they don't have access to the teams, I think is so vitally important. Flo, let's shift to the guidelines to guide preventive care. I know you've been involved in several of these and you're strongly working with ECHO as well. Maybe talk us through some of these.
Yeah, so in areas, and it's sad but true, in healthcare maintenance, this is particularly the case, we do not have very high level evidence that tells us exactly what to do for each patient in each situation. And in these instances, and these consensus guidelines that use expert groups to help us understand care and care pathways take a bigger role. And the way these are done is that the global expert in a certain area come together and vote on statements with concrete recommendations for our patients. And in healthcare maintenance, this includes then obviously gastroenterologists, but includes other subspecialties such as rheumatologists, infectious disease doctors, that then work together to create these items that you can use in your clinical care. What, however, still needs to be worked on, and despite the best possible guidelines, is the uptake of those. And this is a lot in our hands, and the hands of the gastroenterologists and the academic gastroenterologists to accomplish that by promoting these guidelines, talking about them, and through seminars like this one.
And then Flo, the importance of opportunistic infections. I know it's on the slide here, but you already mentioned bacterial infections, which we can't forget. Pneumococcal pneumonia is probably still the leading cause of morbidity and mortality in our patients. But maybe just touch on a couple of the other opportunistic infections we should look out for and how potentially to screen or what we do in advance of starting therapies.
Yeah, so immunosuppression predisposes you to getting these infections. And if you have them, they're more severe than if you would be immunocompetent. The two most common ones, as I mentioned, for anti-TNF, and I'm repeating it to highlight this fact, are pneumococcal and influenza causing pneumonia, both of which are preventable, are in the vaccine program that we talked about earlier. But it also includes C. diff for bacterial infections, histoplasmosis candida for fungal infections, and then HPV for viral infections, for which also a vaccine is available. And we do know that preventive screenings reduce treatment and disease-related complications in our patients.
Yeah, and I think the question is, how do we improve the use of preventive screenings? And maybe talk about this, but then I have a question came in about adolescents, and maybe talk through this first, some of the ways that we can actually improve our preventive screening. Then I'll ask you questions about adolescents with IBD.
Yeah, the approach we do recommend for preventive screening is multimodal, and there are interventions that can be done to improve the uptake of preventative screening. And this includes education to gastroenterologists and patients targeted for each of these groups individually. You can put posters into exam rooms, and then you have patient questionnaires that can be included in the routine workflow. And as an example, the anxiety screening, the depression screening, and many other preventative questions our patients receive prior to seeing us. And when we open the door and open the electronic medical record, we already have this information to incorporate in how, what recommendations we make for our patients and how we treat them.
Yeah, and so one question that came up, Flo, actually there are several questions on adolescents with IBD, and the other night we had a separate program. So for those that may have missed that, please, you can refer to that where we talk about transition of care. But, you know, some of our adolescents patients have a more severe disease course. And obviously we want the patient to do well and get better early. But are there other screening or vaccinations that you recommend, especially around the adolescent?
So I have to admit, I do not see adolescents or children in my practice. There are certain screening questionnaires that provide the readiness for transition of care, for instance, which I think will be a topic of this series as well. So when do you then transition to an adult provider? But in principle, the importance of preventative screening and healthcare maintenance are, I think, identical in adolescents as well as adults, with one bigger difference being growth. And this is particularly true for younger adolescents. Bone health and monitoring growth, trying to avoid corticosteroids, plays obviously a much bigger role than in adults who already finished growing, and then osteoporosis would be the major concern.
Yeah, I think as we get to the next slide on ways to improve quality of care, this can refer and even get to the adolescents, where we need to look at standardization of care, not only in our adults, but in adolescents. Use collaboration. I found that our adolescents, or at least the teenagers that I take care of, are very facile with technology and the technologic platforms, practice guidelines, provider alignment, quality metrics. One other thing about adolescents I just wanted to bring up, and I realize that was an unfair question to you, but that was a correct answer you gave. HPV, human papilloma virus, is something that we are vaccinated, certainly in our adolescent and teenage patients, but also still continuing to screen for depression and anxiety. This is a very difficult time in one's life. And for some of our adolescents, they can actually not express anxiety and depression in a certain way. So I think just for those providers out there that are used to taking care of kids or adolescents or young adults, this is something we need to keep in mind. So Flo, I'm going to move to our SMART goals. We only have about 5 minutes left. There are a couple other questions that are coming in, but maybe I'll go through these and then also kind of wrap up with what's to come next week, but then we'll get to a few more questions that we have at the end. So Flo, I really wanted to thank you for an incredible discussion. The time always flies with you. I always learn a lot from you. And I also want to thank Dr. Ouali, who couldn't be with us tonight, but I think had 2 very impactful videos and really a nice discussion that we had. I just want to summarize a few points. So these SMART goals: recognize the need for preventive screening for our patients with IBD, adhere to the guidelines. I think you did a nice job, Flo, at outlining the guidelines on appropriate screening and immunizations. This collaboration with the interdisciplinary team that we talked about, and the ability now in this medical neighborhood for us to work with communities and through telemedicine. integrating a recommended preventive screening in practice using the checklist, and regularly discussing the importance of preventive screenings with patients with IBD. I want to remind people for next week that we have another program, the Medical Neighborhood, which I've alluded to already tonight in IBD, and the Steps to Improve Care. That's on November 16th. That's 6:30 p.m. Eastern Time. So hopefully people can join us for that. And then just a reminder, we do have a couple minutes here at the end to ask a question. Please click on the Ask Question tab and type in your question. Include the faculty member's name, although there's only two of us, so we'll both answer them. And then we can go from there. And then remember, after the show, there's the question and answer, and then we'll show in a minute the gastroenterology hub with our web link, which is where you can get a lot of that useful information on some of the checklist, the guidelines, cornerstones, Crohn's colitis as well. And most importantly, before we end too, I want to make sure people understand how to get their CME credit, which I think many of you are used to now, but please complete your post-test evaluation online. Flo, there's a question about tofacitinib and Shingrix. What if they only got one of the vaccines of Shingrix before starting tofacitinib? Is it okay for them to complete their vaccination of Shingrix? And I guess the other question is, what if they've never had Shingrix? Is it still okay to give them Shingrix even if they've started tofacitinib?
Yeah, that's a very good question. So at Shingrix vaccination, I think the drug where it's most important is tofacitinib because of the high risk to get shingles. And this is a non-live vaccine, so you can vaccinate your patients while they are on tofacitinib. So if you had one dose and then started, you can complete the second one. And if you didn't have one and the patient is really sick and you need to start the patient right away, then please accompany this with the vaccination for Shingrix.
Yeah,
very good question.
Yeah, no, and the bottom line is it's still okay to give the Shingrix after they've started. Ideally, we give it beforehand. There was a question, I guess, to me about the HPV vaccines in adults over the age of 24 to 26. Actually, the guidelines now are expanding out for HPV later in life. There's questions about will it get reimbursed? That is a good question, although the guidelines do suggest that we can, I think the age, I'm embarrassed to say, I was trying to remember, I think it's up to 45 years of age now. And then one other question on reimbursement for telemedicine. And then Flo, I'll give you the last word before we wrap it up. Do we get reimbursed for telemedicine? And the simple answer is yes, but there has to do with licensing, what states you're in. But the simple answer is we do get reimbursed for telemedicine. So Flo, any last tips or comments before we close it out?
I think my most important tip is please remember to think about healthcare maintenance in our patients with inflammatory bowel diseases. This often falls by the wayside because we all have productivity pressures. We focus on giving the right medications, getting the patient into remission. But it is a very, very important part. And I would like to thank you, Miguel, and CMEO for highlighting this. And I hope there will be many more information seminars to come.
Great. And thanks for everybody who is attending. We had a nice large audience tonight. We appreciate all your feedback. Sorry if we didn't get to all the questions. I did my best, but we do have another program next week. So please join us again next week. But for everybody out there, please stay safe, stay well, and we'll see you again soon. Have a good night.
Bye-bye. See you again.